Welcome to tonight's Immunisation Coalition webinar event. Our topic this evening is meningococcal disease in Australia. My name is Dr. Andrew Baird, and I will be your moderator tonight. Presenting tonight's session is Professor Robert Booy, who will be speaking for around 40 minutes. This should leave us plenty of time to answer any questions or comments that you may have. Professor Robert Booy is an infectious diseases pediatrician. He is currently a senior professorial fellow in the University of Sydney Clinical School at the Children's Hospital in Westmead. From 2005 to 2019, Robert held the position of Head of Clinical Research at the National Centre for Immunisation Research and Surveillance. You may recognise Robert from his regular TV appearances during the pandemic. Thank you for joining us, Robert, and welcome. I would also like to introduce Angela Newband. Angela is an immunisation education consultant who's based in South Australia. She is a member of the Immunisation Coalition. Angela has been involved in the immunisation program delivery in South Australia for 20 years. She presents regularly at our webinar events. Angela is here to answer questions that we have. If I may now turn back to Robert. Welcome, Robert, and over to you. Thank you, Robert.
Thanks, Andrew. Really good to be with you. So this is one of the most exciting talks I've ever given. I've only just written it. The world has changed. We have seen enormous differences just in the last 2 years, but also in the last 20 years in meningococcal epidemiology. And indeed, for the last decade and 20 years, there have been really interesting changes. So the world is changing as well. Meningococcal B cases were reported only last month to have risen sharply in university students in England for the period September-November. The preprint is available. It's not yet published. But they're already exceeding pre-pandemic levels in UK university students. Now, that's curious because meningococcal disease in the last 2 years has been madly going away. But I'd like to suggest, having been in this field now for 20 or more years, the more things have changed, the more they stay the same. We did a study way back in the late 1990s in 144 survivors of teenage meningococcal disease in the UK. I lived there for 15 years. And we published it in the BMJ 15 years ago. And we showed that the risk factors in teenagers and aged between 15 and 19 were especially being either a university or a school student, but also multiple intimate kissing contacts, what some people call snogging. And it had to be with more than one person. Just with one person, one partner was not a risk factor at all. And then, interestingly, exposure to smokers rather than smoke. And that's because smokers more commonly carry the germ, they cough, they spread it around. So that's some epidemiology in teenagers from a couple of months ago and also from over 20 years ago. So what happened during the pandemic? Well, we all know there's been lockdowns to curb the spread of COVID-19, and they were used to great effect in Australia. We've only just opened up this week, allowing international flights back. The UK started lifting its restrictions way back in July last year. And by September, by August, they had historically low levels of meningococcal disease. Now, I'm not giving away a secret to say the same thing happened in Australia. But what happened when people started mixing again and going back to university in person? Well, there was a stark increase in the incidence of meningococcal B disease. And that is in the report. It's from a reputable source, the UK Health Security Agency. And one of the people running that is a former PhD student of mine called Shamez Ladani. So some of the finer print, there were actually 22 cases between September and November, not a lot. And Comparing to 2018 and 19, there were fewer than 20 in those 2 years. So not a big difference. But of the IMD, that means invasive meningococcal disease cases in 15 to 19-year-olds and 20 to 24, almost all of them, 22 of 26, were students registered at an educational institution. So that mixing was really important. And let me tell you a little story about two studies done, again, about 20 years ago during orientation week at universities in the UK. What they did was collect a swab from the throat to look for carriage of meninge every day from Monday through Friday of the orientation week. One study showed that at the start of the week, it was 5% carriage rate, and by the end of the week, it was over 20%. Quite an extraordinary difference, and the risk factors included multiple intimate kissing contacts. So going to the final point, the third point, during the period September through November, there were over 40% of the cases were in institution, compared with only 12 or 14% in the previous two periods. So quite a stark and interesting finding. So let's give you some history going all the way back over 100 years. And we know that meningococcal disease has been a disease that spreads, especially when there is crowding, and wars are a really important point. I hope Ukraine doesn't turn into an awful war, but we know that the First World War, the Second World War, also the 50s, maybe the Korean War, there were periods of major increase in meningococcal disease in Australia. And then it quietened down. But suddenly at the end of the 90s and the early noughties, there was another surge of meningococcal C disease. More on that in a moment. So if we look at the last 30 years, starting in 1991 through to a year or so ago, we see this trend in notifications of proven disease or of likely disease, and they follow each other. And we see especially the trend to a much greater incidence at the end of the 1990s, early 2000s. And curiously, that was driven by two different serogroups, both C and B. And then we saw a large fall off right through the 2000s and reaching a nadir, a bottom line in about 2013. And I was starting to wonder whether meninge was going away. Then it started rising again. We got another peak in 2017, not from two serogroups, mind, but from four, C, B, Y, and W. So why is that? I hope you're wondering. I'll tell you in a moment. So if we look at it by serogroup, we see that B in blue has always been the predominant serogroup. C was very common in the early 2000s, but then something happened. And you all know that in 2003, we introduced universal vaccination for Australian children 1 year of age and above. And that had an immediate and profound effect. And I'll show you a slide on more details of that later. But look at B, it went down too. It went down by about a half. C went down by 95%. So contrasting changes, but both going down. So in a paper that we're publishing with the National Neisseria Network, led by Professor Monica Lara, who worked with us at the National Centre some 15 years ago, Monica and Michael Nissen and Rob George especially are about to have a paper published in the next couple of weeks in the Medical Journal of Australia. And we've used the title, The Silver Lining of the Pandemic Playbook, the fall of meningococcal disease and of influenza in the time of COVID restrictions, the word could have been added. So we explored the reasons for the reductions in these two diseases, not just meningococcal disease, but also influenza, and looked at the control of COVID as one of the explanations, but also the use of vaccines against influenza and meninge. What's going on here? Oh, okay. These are all the people at the National Neisseria Network who contributed to this work. And I'm just one of a big group of people, and I'm especially grateful to Rob George and also to Monica Lara. What happened there? We seem to have dropped slides. I'll go back. Okay, so we suddenly jumped a long way, so I'm taking us back because I know how to adjust. Okay, I don't know what happened, but I'm taking you back to where we should be. So, okay, I showed you that slide, and now the next one is this. This is in the paper that's just about to be published, and it shows that meningococcal B in blue has always been predominant, but C in light blue was a problem 20 years ago. And in 2017, there were 4 different serogroups that went up, and I've named them already. And what do you think was the explanation for that? Well, quite simply, I think it was because we had a huge surge in influenza that year. And if you would have had just one clone of, say, B, then B would go up. But for 4 different serogroups to go up to be different clones, it can't be explained by meninge genetically. It must be explained by another environmental factor, and I believe it's influenza. And the next slide can explain why. And that shows over the course of 15 years that whenever we have a surge in influenza, we have a surge in meningococcal B disease in Australia. So although the slide is a little busy, it purely shows that the two coincide with each other. A surge in flu, then 2 weeks later, a surge in meningococcus. And we looked in the literature, and the same thing was found in the United States as well. So both flu and invasive meningococcal disease are diseases of crowding. Going back to 1918, more than a century, a paper was published in the BMJ showing 6 predisposing factors. Look at the last paragraph: season, severe weather, epidemics of flu, lower immune resistance, overcrowding, and a high carriage rate. I've touched on those a bit already, haven't I? Okay, so flu and meninge are diseases of crowding, as is COVID. So since 2003, we've had routine meningococcal C vaccination in Australia, which has made a big impact. For B, we've been much more recent in our changes. In October 2018, a B vaccination was funded for eligible children. That is mostly high-risk children, a small percentage of the population, but also was given to children in South Australia, and I want to talk about that study. Indigenous Australians have been indicated for free vaccination on the NIP since July 2020. Their risk of meningococcal disease is 5 times higher, and that's why they're being vaccinated ahead of other children. And I'll let you read the last paragraph. So the result of all the COVID measures and all the vaccination is that we have now had 2 years running lower and lowest rates of invasive meningococcal disease and influenza since national records were ever kept in Australia. So it makes you think, will these diseases go away? No, they're not. So the broad scale public education strategies have disrupted transmission. We've seen that. Point 2, general awareness of infection control has improved. You hear about it in the television every day. Recent findings of changing social behaviours with distancing and with mask wearing have also had an impact. And the reductions in case numbers achieved for COVID have spread to impacts on flu and meninge. So here's a slide going back 20 years, just to concentrate on meningococcal C for a minute. This is a paper published by Glenda Lawrence from the National Centre. I helped write it more than 5 years ago, and it looked at the rates of disease by age band. And if you look at 2002, 2003, when the vaccine was introduced, you can see quite starkly that people over 25 were being dramatically affected, as were 15 to 24-year-olds. So it was a disease and epidemiological problem of young adults and older teenagers. Very interesting. So meningococcal C was doing that. And when you go back in history, there are other examples of when a new clone comes along that it affects young people more than children. So that's an interesting sideline. But as I pointed out already, if you go to the right-hand side of the slide, 99% reduction in meningococcal C over the course of just less than 15 years, and a 55% recurrence in meningococcal B. So why did B go down if we didn't have a vaccine? Well, that's a really good question, and we can come back to it later if anyone's interested. So here it is, vaccine introduced, disease goes away, but a little surge in 2017. Remember I said that adults have a problem with MenC? Well, men having sex with men in 2017 accounted for many of the cases in 2017, as did a prior influenza infection. So epidemiology is interesting. There are multiple risk factors that can operate together and concurrently in the same person. Fascinating. What about meningococcal B? There you see that downward trend. It was in Australia the most common serogroup every year until 2015, and it was eclipsed for a short time, for a year or two, by meningococcal W, which suddenly surged. And meningococcal W had actually surged way back at the turn of the millennium, 2000, 2001, at the Hajj. I was working in London at the time. We did research, and we showed that a handful of adults came back from the Hajj, from the pilgrimage in Saudi Arabia, carrying the germ and developing disease. But then they spread it to a dozen children in the East End of London. So the main problem was not at the Hajj for us, but the adults bringing back the germ and giving it to their children and to their community. And we got a dozen children who developed meningococcal W disease in East London, and 2 of them died in our emergency department. So it was not a trivial problem. Going back to 2017, we had that spike of 4 different serogroups, flu-driven, and then we had the introduction of ACYW vaccination soon after that for teenagers on a state basis, but later it became federal in 2018. So I'll just keep going. If we look at 2017 in the red in the slide, in the graph at the top, we see a surge in influenza-like consultations due to influenza. But also in 2009, there was a surge in consultations due to the pandemic H1N1, the so-called bird flu. The 5-year average was much lower. And so there you see the epidemiological association. So what can we do about meningococcal B? There's a multi-component recombinant vaccine available. It was first licensed in Australia in 2013 called Vaccination. It covers broad spectrum meningococcal B clones and strains. It was registered from 2 months of age in 2014 and has largely been on the private script for most children, but in South Australia, it has been more widely used. TAGI targeted its use for under 2s and 15 to 19-year-olds, populations at increased risk. That's a tiny proportion of the population. People with immunodeficiency, without a spleen, people occupationally exposed, and so on. The PPAC has repeatedly felt that the cost-benefit relationship isn't strong enough to introduce it. We have a paper coming out in a month looking at equity, that poor people are the people most likely to catch it, whatever your ethnicity, and we think it should be more widely available, especially to people living in more crowded conditions with lower incomes. So what did they do in South Australia? Tremendous work by Professor Helen Marshall, who's the Australian of the Year for South Australia. They noted 5 years ago and more that invasive meningococcal disease was high in South Australia, especially due to MenB, and half of the cases were in adolescents, teenagers. So they did a trial, a cluster randomized controlled trial in high schools to look at the impact of the vaccine, the multi-component vaccine, against carriage of Neisseria meningitidis group B, serogroup B. The long and the short of it was that they showed that the vaccine did work in individuals, that it prevented disease, but there was no impact on carriage. It did not prevent one person who was carrying the germ spreading it to another. So the impact of the vaccine is very much on the individual, not at the public health level. So meningococcal B vaccine, I'll come back to that in the questions if you want. Meningococcal W in Australia had that surge in 2016-17 and then started declining. When flu went away in 2018, so did meningococcal serogroups. And there was another impact though. Not only was there improved vaccination against flu and flu went away, but meningococcal W was being vaccinated against from 2017, especially in teenagers. I've mentioned already the story from 20 years earlier, working with pilgrims I'll let you look at that. I won't go over it. It's been a worldwide issue, not just an issue in Saudi Arabia, but also in the Sahel, in Northern Africa, in the sub-Saharan regions, and in other parts of the world too. Here's a slide I really like. It looks a bit busy, but actually take a moment. If you look at the red rate of disease in age groups less than 1 to 4 years, 5 to 9 years, etc., etc., the red lines are going up everywhere in 2016-17. And this is the rates of Mendw disease, except in 15 to 19-year-olds. And why was it coming down in 2017? Well, I suggest to you that this is stark evidence of using a vaccine in a particular age group works. And that's why, because only teenagers were being vaccinated, we see a drop-off in 2017 that we don't see with other age groups. But let's go on just 1 year. So this sudden surging in 15, 16, 17, what happened after flu went away and we had a quiet flu year in 2018? Well, the Honourable Greg Hunt said we'll have the vaccine for everyone. It seems to be working nicely, so the whole country did it. And 2018, what an extraordinary epidemiological change. Every age group, it went down. So I just find that quite astounding. What about W? What about Y? One more. It too increased, and we've gone over the reasons why. Back in the early 2000s, it didn't account for many cases, but then in 2016, the rate of Y went up as well. And you can see that in the graph. So I'm going to come to a summary now. We have seen in the last 2 years extraordinary changes in social and public health behaviour, in work practices, in using masks, in social distancing. And our modelers have said if people would only just comply, if we had 80% compliance with actions to stop the spread of coronavirus, we could control it even without a vaccine. That's what that suggests. But if you only have 70%, you couldn't get control. Now, modelling is only as good as the parameters that you put into it, and sometimes we don't know the variables that we're putting in, all of them. And so it makes it hard for modelling to be accurate for more than a month or two after it's used. Suffice to say that we all know that these measures did work in the first year and a half. Then Delta came along and it got even more transmissible and harder to control. And then Omicron became an overwhelming surge, a tidal wave of COVID infection. So if you look to the middle of this slide, in 2020 in Australia, for the first time in history, the notifications of invasive meningococcal disease were less than 100 in a year, only 90, the lowest ever recorded. It was thought that a combination of social distancing, masks, and other health policies, higher influenza vaccination uptake in 2020, decreased influenza especially, and the improved use of quadrivalent meningococcal disease, all of those things probably helped. And by 2021, it was even more stark, a further large decrease in meningococcal disease in Australia in 2021. Now, remember I told you that from September 2021, the UK had a sudden surge. So these kind of epidemiological observations can quite rightly be said to have never been seen before. Common illnesses were wiped out by our fight against COVID, vaccination and other measures. Quite extraordinary. So I want to leave it there. I've said already tremendous thanks to colleagues from the National Neisseria Network, especially to help in many of the slides from Professor Monica Lara. And I'm going to stop there, and hopefully you might have a question or two that I can answer.
Well, many thanks, Robert. Thank you for a most interesting and informative presentation on what I guess I could say with all those graphs was the ups and downs of meningococcal disease. Robert has presented us with many interesting concepts and ideas around the current state of meningococcal disease in Australia. A first question, Robert, if perhaps you could make the answer. With the ACWY vaccine. What about this for older people, say people aged 70? What are your thoughts on that, Robert?
So the epidemiology is fascinating. We know about the high incidence in children just a year or 2 or 3 of age. We know about a second peak in older teenagers, very early 20s. But there is actually a third peak in people over 65. And there's some reason to think that ACYW quadrivalent vaccine would be worthwhile for them. I'm certainly going to get myself a booster before I'm 65. I think it's worthwhile. When you look at the epidemiology, serogroup W and Y can especially be more common in older people. Y serogroup can cause pneumonia. W can cause blood poisoning and meningitis. Even B can occur in older people. And as I've mentioned, C has been seen in young adults and also men having sex with men, and it can occur in older people too. So for me, even if it's not free on the NIP, I think it's a worthwhile vaccine to have for an older person. And because it's a conjugate, it probably gives you protection for 5 to 10 years, so you don't have to do it every year.
Do you know how much it costs, Robert?
No.
No. So just on thinking about funding and funding for meningococcal vaccines, I have a patient who's had a stem cell transplant. Are they eligible for a funded meningococcal vaccine?
Well, the first thing I would say is that immunosuppression is a strong indication for vaccination. And my reading of the National Immunisation Handbook suggests that immunosuppression, which is especially known to cause meningococcal disease, like having no spleen, like having a bone marrow transplant, that's a stem cell transplant, the use of eculizumab, which is a monoclonal which knocks out the immune cells which fight meningococcal disease, that especially is important. So I think it's worth pursuing. I'm not a GP, I'm a simple pediatrician, but to the best of my knowledge, someone with a major immunosuppression would benefit from such a vaccine.
Oh, excellent. Thank you, Robert. And here's a question probably a little unfair for a pediatrician because we're again looking at the other end of the age spectrum. So we've got a question from Alison who wonders what other vaccines other than the National Immunisation Programme vaccines would you promote as we get older?
Oh, I'd love to answer that. I went to my GP and I took advice and I had 2 boosters only last week. I've had a DTaP, a little d, little t, acellular pertussis. I hadn't had one in 15 years. My other arm, I had a pneumococcal conjugate to cover pneumonia. I'm going to get my shingles booster next. I've had my 3 COVID vaccines, so I'm covered in that regard. And there's one more, isn't there? Influenza. Right. So that'll be available within a few weeks. So I had a booster at Christmas of COVID. I've had 2 vaccines last week. I'll have another 2 in the next few weeks.
You mentioned influenza, Robert. What is the uptake of influenza vaccination been during the first 2 years of the pandemic?
Well, it's been fascinating. We had 18 million doses given in 2020. That's tremendous. People didn't have a COVID vaccine, so they said, well, at least we could prevent flu. And they came out in their droves and they were vaccinated. Therefore, the industry supplied 20 million doses for the 2021 season. But by then we had COVID vaccines and all people wanted was COVID. So half the doses that were supplied were left in fridges. So the uptake was probably 10 or 12 million last year, having been 18 million the year before.
Thank you, Robert. A question again. This is more letters, and this is the sero groups. The question is why can't B be put in with A, C, W, and Y? So we've got a pentavalent vaccine.
Well, that's a lovely question, and it is actually being done in research studies, mixing the two. And to the best of my knowledge, they're working out as both safe and immunogenic. It's not yet licensed. So the work is being done. The work is being done. It's just not available yet.
There was a point of information, Rob. It goes back to your initial slides on meningococcal B, and the question is: does this apply to all meningococcal B, all types of meningococcal B, all subtypes?
Does what apply?
You'd shown the statistics of the decrease in meningococcal B and also the increase of meningococcal B. Those original studies that you've done with university students and school students in the UK. So was that all meningococcal B or particular subtypes?
Yeah, so there's two answers to that question. One is that the multi-component vaccine does cover 75 to 80% of B disease. So it's not perfect, but it's very good. The second answer is that meningococcal B routinely acts in a clonal way. So there tend to be particular clones which are more prominent and more common, and they are mostly covered by vaccine as well. So when you have sudden surges, it's often due to one or two or maximum three new clones coming along, more often just one or two. And when you have declines, it's the same thing. You're getting control through various public health measures, and it impacts on all. The ones that it least impacts on are those that, for some reason, have greater transmissibility, and that's a subject of a lot of research. Some people find that bacteria which have thicker capsules are more likely to transmit. I don't actually have good data on that for meninge B, I'm afraid. Sorry.
Oh, thank you, Rob. Thank you very much indeed. And I'd just be mindful again. We'd love you. You do have to go. Thank you so much, Rob. Thank you for an excellent, wonderful presentation. Lots of things for us to think about. Thank you for your contribution to the Immunisation Coalition. So many thanks, Rob. Thank you.
Bye-bye.
Yeah, thank you. And Angela, many thanks for joining us this evening to help us as we work through meningococcal disease. We discuss some of the concepts around meningococcal disease, and it's wonderful to have you here to provide some expertise and input for us. So we do have some questions which Rob was unable to answer. So if you're okay, well, perhaps I could start with some of these questions. Then one question which has come up is about Nimenrix. And the question is, what about administering it with other childhood vaccines? Can it be co-administered or not? What can you tell us, Angela?
Okay, great, very good question. Because of course, some children are receiving, or some infants are receiving Nimenrix, from 6 weeks of age, which is when we're giving our Infanrix Hexa vaccines. The recommendation is, yes, co-administer them on the same day. There is a little question mark around Nimenrix being administered close to another tetanus toxoid containing vaccine. But the recommendation is to definitely co-administer. If they're not co-administered, the data is not all that conclusive. And so therefore they would say, go ahead and administer the doses as they should be administered, because it is about offering as much protection as possible to these young infants.
So I guess I had a question which is related to meningococcal disease, but viral meningococcal disease. I mean, Rob has focused on bacterial meningococcal disease, which is clearly of great importance, but we do see viral disease. Do you know of any changes that have occurred with the incidence of viral meningococcal disease over the last over the pandemic years?
Yes, I've not seen any data, to be honest, Andrew, around viral meningococcal disease or meningococcus. So certainly the focus is so much on the bacterial meningococcal that Robert has focused on, purely because many of those, well, we've got 5 strains that can at least be vaccine preventable. So it is about getting those vaccines in to reduce that likelihood of those infections, which obviously can be, a really very, very serious disease. And, and unfortunately, we do lose people every year to those bacterial meningococcal infections. But as far as the viral meningococcal rates, I've not seen any data recently.
And I was wondering whether viral meningitis included COVID, whether COVID causes viral meningitis. Do we know about that?
Well, from the data that I've certainly been seeing around, the long term of COVID, I suppose, and it seems to be a virus that is affecting more the solid organs, so definitely kidneys, certainly lungs, most definitely. Whilst there does seem to be an increase in mental health conditions as such, I suppose if somebody did particularly become septic, then of course, obviously that can certainly lead to an encephalitis of some description if they became completely septic. But mostly the talk that I've, certainly been hearing is more so that, those solid organs of kidneys and lungs and heart and livers.
We're learning all the time, aren't we, Angela? So
we are learning all the time. The one thing that didn't happen with this pandemic, really, Andrew, is that it didn't come with an instruction book. No. So, it is, we often talk about flying the plane as we build it. And we've just had to have been doing that for the last 2 years, leading into our 3rd year now, for sure.
Thanks very much, Angela. And returning to bacterial disease, and I have another question, and this is from Karina. And Karina has asked a very interesting question, was why did the drop in meningococcal B cases occur with the introduction of ACWY vaccine? So that seemed a paradox. So can you explain that?
Yes, and I think that's just such an interesting question, and I think I'm just going to echo Robert's words. Really, is that epidemiology is just such an amazing thing, isn't it? We and not fully understood as to why did one serotype drop when another serotype dropped. So there's some questions that I certainly don't have the answers for, and I think Robert sort of definitely alluded to the fact that it's a bit of sometimes an unknown phenomena to why that would happen. So we just need to still be so mindful, I suppose, that meningococcal B disease is really still a prevalent serotype, and we need to protect these individuals as much as we possibly can, particularly these young babies and particularly our teenagers, and of course particularly our Aboriginal and Torres Strait Islander children that are eligible for the funded vaccines. And I'll just expand on a little bit around the hematopoietic stem cell transplant patient for that question that was asked earlier. Certainly any patient that has had a hematopoietic stem cell transplant has got an increased risk of meningococcal disease. Vaccine would be highly recommended, but unfortunately not funded under the NIP. So the funded program is very, very narrow, and certainly Robert covered some of that. The asplenic people or the hyposplenic people, complement deficiency, and also those that are receiving that eculizumab drug that tends to really put people at risk. So that's really, the really specific criteria for the funded ACWY vaccines for sure. But HIV individuals also, most definitely be recommended for them. Your other thing I'll just mention with your hematopoietic stem cell transplant patient too is that if this is the first year since they had their transplant, you should really be offering them 2 doses of influenza vaccine this year. So if this is the first year post-transplant, then it's 2 doses of flu vaccine 4 weeks apart. And then from then on, just a single dose each year. And the same goes for your solid organ transplant patients. If any of the audience has any of those that have had a solid organ transplant recently, if this is their first year following solid organ transplant, it's 2 doses of flu vaccine 4 weeks apart.
What happens if it's 5 years following their solid organ transplant, but they've only had 1 dose each year until then? Do you still do?
No, it's just in that very first year post-transplant that it applies.
So if they've missed it, that's too bad.
That's too bad. Absolutely. And it's the same, really, Andrew, with those, young children under 9. If they're having flu vaccine for the very first time, it's 2 doses 4 weeks apart.
Sure.
But if they started off with 1 dose and now they're 5 years down the track of having flu vaccines every year, then they don't get that second dose.
That's really helpful advice, because I can certainly think in my case, there are several patients who unfortunately have not had optimal treatment. They've not had their 2 doses when they should have done. So it's good to know how to act.
Sure.
We've been talking about Nimenrix. I've got a couple more questions, a couple of link questions, Angela. Firstly, is how early can Nimenrix be given? So at what age in infancy?
Okay, so the vaccines are licensed from 6 weeks of age, and that is the preferred vaccine. It's the funded vaccine that's on the schedule. Obviously, for babies that are that young, often are coming in with prescriptions at the 6 weeks checkup. So perhaps the paediatrician that they have seen has sent mum off and suggested that they start the baby off with Nimenrix at 6 weeks of age. That certainly can be given. Always prioritise, for the providers listening, always prioritise the NIP funded vaccines. So if you're feeling a little uncomfortable about giving multiple vaccines on the same day, always prioritise those NIP vaccines and bring the baby back in for those unfunded vaccines. So, yes, you would give a dose at 6 weeks of age, you'd give a second dose at 4 months of age, and then they would get their free dose on the schedule at 12 months of age.
And you've answered the second question, which was,
right.
do they still get the 12-month vaccine? So that's still the case. Yes.
Absolutely, yes, most definitely. We would want them to have that dose at 12 months of age, or certainly shortly after 12 months of age, to complete their schedule.
I was asking Robert about costs, and he was not going to offer anything. So I'm going to put you on the spot with a cost question. So we've got a question here from Jody, who's wondering what's the cost of meningococcal B vaccine for someone who doesn't qualify under the national whatever the state-based program. How much does Men B cost?
Look. As a general rule, around about $120 for the dose, around about. What I would strongly always suggest, if you are writing prescriptions for patients to purchase vaccines, advise them to let their fingers do the walking, phone around 6, 7, 8 different pharmacies. They will probably get 6, 7 or 8 different prices, to be honest. But also, if people have private health insurance, most private health insurance companies will give some type of a rebate back on purchased vaccines. I recently purchased Shingrix vaccine for myself. Now that's a $270 a dose vaccine, and I ended up only paying around about $79 for the dose after claiming off my private health. So most definitely, if people are on private health, check with their private health company. Unfortunately, it's not PBS listed. So if people do not have private health insurance, they will be paying full cost with whatever the pharmacy is charging.
Yeah. A question from Alison, and this question is really around COVID and COVID vaccination, but not so much the COVID vaccines. It's the implications of the COVID vaccination campaign. So what has happened to other vaccinations? Have other vaccinations rates increased or decreased or stayed the same? Do we have any information on that, Angela?
Look, I'm going to say we've got anecdotal evidence, I suppose, that rates may well have dropped. Definitely with a lot of practices that have gone to telehealth consults. There may have been missed opportunities, obviously, to have their children vaccinated, particularly if they're on catch-up schedules, etc. But, you know, the last lot of data that came from the Australian Immunisation Register seemed to be very good. It seemed that we are holding our immunisation rates very, very well. We still have a funny little dip around about the 18-month scheduling point, but it seems that children are getting caught up before they reach 4 years of age, which is good. So I think time will tell. Probably the next round of data coming out may be a little clearer to what has happened with immunisation rates. But I think, you know, certainly things like, you know, the no jab, no pay type policies now, parents are, you know, so much more on the ball about getting their children up to date because it's required for childcare purposes. So hopefully our rates aren't going to be dropping too far. I think probably the concern that we have for the providers is that they're going to get a lot more questions now because, you know, there's been so many questions raised from COVID. We now have vaccine experts, it seems, on every street corner and in every suburb. And so people are sort of questioning vaccines a lot more now because they're suddenly hearing about a spike protein. You know, we've been dealing with spike proteins in flu vaccines for a long time. You know, we've got our hemagglutinins and our neuraminidase. So it's nothing new to us, but it's new to the community. So I think, you know, providers may start getting a lot more questions about what's in a vaccine. Has it been tried and tested, and how long has this one been around for? So I think we're certainly expecting a really horrible flu season. Now that our borders are opening, we can see that the flu data from the Northern Hemisphere is leaning towards a H3N2 year. If that comes to Australia, then we always have a bad year if we've got a H3N2 year. So, and we've got so many people in our community now that haven't been naturally boosted by having circulating flu disease. And we've had a lot of people that haven't bothered having a flu vaccine because there's been no flu around. And certainly those little children that haven't been vaccinated and haven't been contracting or sort of, you know, having any contact with influenza, they are completely flu naive. So we've got a really great concern about flu season this year. So, and, you know, like Robert said, there seems to be this association between, you know, circulating influenza disease rates and meningococcal disease rates. So, you know, I think we need to keep our eyes pretty open. Absolutely.
Oh dear. So it sounds like the perfect storm, Angela.
Oh, it could be the perfect storm.
Yes.
Because in you know, with borders opening, we'll see other things coming back, like measles. You know, we haven't had any measles cases either with borders closed. So I think, you know, it'll be an interesting year. It'll keep us on our toes.
But I'd like to ask a question, and it's going back again. It's another ACWY. I think that's been top of the list for today's questions. So, and the question is the adolescent program going to continue? once the younger kids who've been vaccinated at 12 months reach adolescence, reach that 14, 15 years of age. So, or what's going to happen? What do you think, Angela?
Look, great question. And, unfortunately, I think, as much as we would all love a crystal ball to look into, we don't have it. We certainly have seen adolescent programs fall by the wayside as children have, been vaccinated in their early childhood. We saw it with the meningococcal, with hepatitis B programs and varicella programs, etc. So it will depend on the recommendation at the time, because at the moment we know that it's a single dose only vaccine after 12 months of age. We don't need another one. However, by the time these little children get up to high school, the recommendations may change. We'll see what happens in regards to, whether there's any waning immunity over time. Being a conjugate vaccine, we're hoping that the immunity will hold for, long term. But whether we need boosters at that stage, who will know? But if, the data is looking good and we all seem to be still covered, then I would suspect that teenage program will go by the wayside. But until we get a bit closer to that point and know what the, all of the sero surveys are telling us, it remains to be seen.
Thank you, Angela. Once again, you've answered the second part of that question in your first part, which was about waning and how long does efficacy last, and do we need to have boosters? But again, watch this space with.
I think so.
Look, I will. I can ask one more question because it's a practical question. So we're getting Lindsay is asking for some help. So the uptake of ACWY in the high school cohort through the school immunisation programme was only 65%, so not as high as hoped. So what Lindsay's wondering, do we have any media-based material that could be shared with parents and students to help to improve uptake? Is there anything that might help us, Angela?
Look, state and territory health departments may well have some material that can be going out more so to parents. Obviously, the vaccine companies themselves are a little bit bound by the rules and regulations around promoting directly to the public. But, there are some other bodies, Meningococcal Australia, etc., that talk very broadly around all of the serotypes and the vaccines that are available, who are the risk categories, etc. But I would love to see some, education programs being delivered in the school to these students, so they can be really stressed the importance of having all of these school-based vaccines, because we're seeing, not optimal uptake of, the other school-based vaccines as well, your DTP boosters and HPV vaccines. So from across the board, if I had a wish list, on it would be in school classroom education from an immunisation nurse, talking about how serious these diseases are and the importance of getting those vaccines.
Well, let's fly the flag for that initiative, Angela.
Yes, exactly.
I'm with you on that. And on that very positive note, we'll close this evening's webinar. I wish to thank Robert in his absence for an excellent, helpful, informative presentation and for his answers to questions, and to thank Angela very much for coming along and joining us and helping us out with some very difficult and challenging questions and some excellent and helpful answers. So many thanks, Angela.